Well, that's what we do in church. We talk about mourning all the time. So my name is Gary Haas, and I'm going to coordinate these forums. Glad to have you here. If this is your first time, we'd like to have your email, and we use that only for information about this event, the forums each month, as well as our Memory Cafe program. So two things that we do. And today I'm delighted that we have Dr. Gomer with us. Next month in March, instead of the fourth Thursday, we will be meeting on Tuesday the 24th. And that's the reason. The reason is because the person that we have coming, Dr. Alan Anderson from Banner Dementia Studies, Alzheimer's Association Studies, right, will be with us. He's a geriatric psychiatrist, so he's going to talk about dealing with difficult behavior. He's very good. He does a lot of hands-on kind of stuff, so he will be with us on Tuesday, the 24th of March, for 2 o'clock, the 2 o'clock time. We only have one time for everything we do. It's 2 o'clock. So our Memory Cafe is at 2 o'clock on the second Thursday, and this program is usually at 2 o'clock on the fourth Thursday. Dr. Gomer has been with us several times before. He's always insightful and challenging. He's given a number of talks on different things, different aspects of aging. I first heard him when he talked about the difference between I think the topic was, what is normal aging? And we all were blown away by realizing how much happens to us as we age, just how much our bodies change, our mind change, our brain changes, all of that. So we learned a lot, and he's been with us 2 or 3 times since that time, and we're just delighted that he's back with us. And he and his wife, Eileen, have got their truck all ready to go from here to Parker Lake. So we will have the joy of having him with us for this presentation. Unfortunately, Donna and I have a doctor's appointment in Tucson at 4, so we are going to need to leave right at 3. And so Dr. Gomer has said that he will be around afterwards for any conversations that you want. And both of our pastors are here too. Pastor Ken and Pastor Doug are here, so I'm glad that they'll be here. So if there's any questions that you have or issues about advanced directives, feel free to consider those things. So with that, you have a mic that I think he has a mic too.
I think I'm mic'd up.
Okay, you're mic'd up, all right. Yeah. But your name isn't Mike. It's different.
No, it's right.
Thank you so much.
Yeah, well, thanks.
Thanks for coming.
Can you all hear me okay? Yeah. Hi. I'm Tim Domer. It's good to be back here again. I'm starting to see a lot of familiar faces when I give these talks, and it's always a pleasure for me to talk to you all as well. So today's talk is going to be about what happens with advanced dementias. And I put an S on the end of that because dementia comes in many different forms. But in general, the process or the progress of dementia follows a fairly expected course. Now, how quickly it follows that course and the bumps and the hills and valleys during that course can change person to person. But overall, there are certain things that can be expected with the advancement of dementia. And so that's sort of the context of this talk today. Jerry actually contacted me and asked if I would give a talk on nutrition because he heard that I gave a talk on nutrition to one of your other churches here. And I said yes, but when you're talking about nutrition in the context of dementia, it's probably not the talk that you were expecting. So I did talk to him before I put this thing together to make sure that it was going to be acceptable. So that's what we're going to be talking about today. For those of you who don't know my background, I'm a retired internist, but I did a fellowship in geriatrics and palliative medicine. And I worked for about 24 years upon the Navajo reservation and started an elder care program and a palliative care program. And I've spent probably the last half of my career was with older population and with taking care of people who were reaching the end of their lives, whether it was in palliative care or hospice. And we're going to talk a little bit about those things towards the end too. So are you want to do this thing?
Unless you don't have
I have it, just this clicker, but I don't think it's I don't think it's not a clicker.
There is a remote.
No, this is mine.
Oh, you got yours.
I'm just going to use this as a pointer. Okay, so we're going to be talking about the prognosis and expected course of dementias today, as I just went through. And then we're going to be talking about decision making. And with any disease that is advancing, and actually, to be honest with you, with every single human being, because the only sure thing in life is that no one gets out of it alive, right? People say death and taxes, but a lot of people don't pay taxes. But to prepare for the end of our life, like we prepare for everything else while we're alive, it's important to put things in place. But when we're talking about the dementias, it's of particular importance because the nature of dementia is that the person who is most affected will not be able to make decisions ultimately, right? That's the definition of dementia. So this is a little bit different than like if you had heart disease or liver disease or a cancer of some type, where you could speak for yourself until very close to the end. And we're going to be talking about quality of life as the context of making these decisions versus quantity or the extension of life. And generally, we're talking about the artificial extension of life, okay? And just to be clear, and I'm going to go over this again, when we're talking about artificial life support or whatever you want to talk about, anything that we do to somebody that they don't already have, that God gave them, is artificial, right? So people think of CPR, they think of ventilators, being on a breathing tube or on dialysis and all that kind of thing as being artificial life support. But artificial life support also includes oxygen. If it's anything above the 20% oxygen that we breathe all the time, that's artificial. It also includes IV fluids or feeding, artificial feeding, antibiotics. Anything that we do is artificial, right? So when we're talking about artificial life support, it's important, or artificial extension of life, it's important that we are clear what we're talking about, okay? And then we're going to talk a little bit about palliative care and hospice. So how do we handle these situations? Okay, next. It's important to remember that dementia is a terminal illness, okay? Dementia is irreversible brain failure. We're used to talking about heart failure, liver failure, kidney failure, etc. Dementia is brain failure. And when you talk about an organ failure, and you're making decisions for that individual, you think, well, what does that organ do? Okay? If it's heart failure, we understand what the heart does. Same thing with everything else that I just said. Well, when we're talking about dementia and brain failure, what does the brain do? Next. It's important to understand what the brain does because it's going to impact how we make decisions, okay? So the brain obviously is the seat of our cognition. Everything that we know, everything that we feel, everything that we understand, everything that we think we understand is in the brain, okay? That's how we experience life, is in the brain. It's involved with our decision making. It's involved with our volition. If we want to do something or we don't want to do something, that is all in the brain. It's involved with our emotions. Those are in the deepest part of the brain, okay? All of our emotions are seated in the brain. And the brain is also concerned with our personal safety, okay? If we see something that we think may injure us, then we act accordingly. We also have systems that, for example, if you put your hand on a stove and you didn't realize it was on, your brain is going to sense that even before you necessarily do, and it will pull the hand back before you get burned, okay? But all of that circuitry goes through the brain. So the brain is involved not just with thinking, but with all of the other things, emotion. And next week you'll have somebody who's talking about behavioral issues and that sort of thing. Well, that's the brain, okay? The brain is also involved with bowel and bladder control. People may not understand that, but when you have the urge to either urinate or to defecate, the reason that you have that urge is because the brain received those sensory inputs from the bladder or the bowel that the bladder needs to empty or the bowel needs to empty, and you seek the proper place to do that, right? The brain is also involved with feeding. Our sense of hunger goes through the brain. Yes, there are chemicals in the stomach that will sense if the stomach is empty and will be released to make us feel hungry so that we go find food. But the sense of being hungry or seeking satiety is in the brain, okay? So all of those things are affected with dementia because they're all involved with the brain. Next. Now, we're not going to talk about early dementia in much detail. We're mostly going to be talking about advanced dementia, but I'm going to come back to early dementia because that's when decisions need to be made. But there's a number of different scales or systems that are in place where we sort of idealize the progress of dementia. And we say, well, people go through these different stages. Well, in general, people will go through those stages, but you can't tell from one person to another either how quickly they're going to go through a stage or how that stage is really going to affect that individual, because there's a lot of things that go into our brain. Everybody's life is different, everybody's experience is different, and so everybody's brain is different. But this is one called the Global Deterioration Scale, and that's used fairly commonly. And stage 1 is that there's no apparent signs of dementia, and this would be done in retrospect. Stage 2 is mild forgetfulness, and forgetfulness, as we learned about normal aging, is part of normal aging, but mostly it's because people weren't paying attention, right? Most of forgetfulness is where you really weren't paying attention. Stage 3 is more frequent forgetfulness and maybe clumsiness, not so much clumsy that you're falling, but just clumsiness with things that you used to be able to handle pretty easily, okay? Stage 4 is obvious memory loss, cognitive decline, confusion, disorientation, somebody who may get lost in a place that they had been many times, those kinds of things. Now, it's obvious to anybody who's watching this person that this is more than just forgetfulness, okay? They're getting confused at times. They used to be able to cook, and now they really are putting ingredients together in ways that don't make any sense at all. So that would be like stage 4. Stage 5 is major memory loss and now some physical dysfunctions. I mentioned bowel and bladder issues. Stage 6 is severe decline. This individual would need help with getting dressed, with toileting. They would not be able to take care of their finances and anything like that. And then stage 7 is basically bedbound and depends on somebody else to get nutrition, okay? And in stage, because they can't feed themselves. And in stage 7, or very end stage dementia, this person probably isn't hungry, okay? If they're hungry and you feed them, they want to eat it, great. But if they don't, they're not hungry, okay? If they push the food out with their tongue, they're not hungry. If they clamp their teeth closed, they're not hungry. They don't want to eat that food. We're all used to, we got to eat something. Well, in this stage of the disease, that's not what's going on. Okay, next. This is the FAST scale, and I'm not sure if I went through this with this group before, but this is an assessment that's used in hospice, so I'll come back to this a little bit later, so we'll go through it fairly quickly. But this is a staging system that's based on 1 through 7, and 6 and 7 are then subdivided. But stage 1 would be no difficulties, no dementia, kind of like the beginning of the global scale. Forgetfulness, difficulty with the job, some difficulty with traveling to new locations, having trouble getting oriented. And now we're having more difficulty with things like flushing the toilet or preparing a meal or handling tasks that we used to be able to handle easily. But when we're down to 5, now we're not even getting dressed properly. We need help with appropriate clothing to go outside when it's raining or too hot or too cold. And next is having actual difficulty putting those clothes on and then not being able to bathe properly, needing some help with, for example, adjusting the bath water. Somebody could burn themselves. and then being unable to handle toileting properly, this person forgets to flush, or you find that they threw the toilet paper in the corner, something like that. It becomes very evident that they're not taking care of themselves. By stage of 6D, they're now incontinent of urine, and then incontinent of stool. I mentioned that the brain is involved with both of those functions. And then when we reach stage 7, this would be more severe dementia, and they're losing the ability to speak because our brain is involved with both the written word and the spoken word and understanding words. So this individual would have difficulty speaking and maybe only says a half a dozen recognizable words a day. And then moving on down, they get to the point that maybe one intelligible word a day. And then they lose the ability to speak. By 7C, the individual will have all of these advanced issues in place, but now they're unable to walk without assistance. 7D, they're unable to sit up without being propped in place or something like that. And then finally, 7E, they're unable to smile, and there's F down here, which is hidden, and they can't lift their head off the bed, okay? So that's a staging scale that is used in hospice. Now, if you turn the thing upside down, you will see that's exactly how our brain develops from birth. We're born, we can't lift our head up, we then smile and everybody gets all happy. It was their first smile. And then we start to walk. We're falling all over the place, but we do learn how to walk, and then we learn how to talk. First, you can't understand a damn thing the kid says, but then they learn how to speak properly, and you wish that they hadn't because they won't be quiet. And then they learn how to go to the bathroom instead of soiling their pants, and the same thing with the urine. They can flush the toilet. They can take their own bath. At first, they don't know how to put on the right clothes, and you have to help them. And then they put the right clothes on, and they get themselves dressed nicely. They go to school, and they can start performing tasks. They get a job. They become the boss. And they go on vacations and etc. And there we are with a full cognition, right? So dementia is the undoing of how our brain developed in the first place, okay? And I think that that's helpful when you're thinking about dementia to put that in that context, because it's also going to affect how we make decisions. Because if somebody is up here in this area, it's not going to be too long before they're not going to be able to make decisions that are going to have any legal significance. And we're going to talk about that a little bit. Okay, next.
Doctor, could I ask a question?
Sure.
Is there any set amount of time between 1 and 7?
No. It's different for every person. I've seen people who they were diagnosed and they were dead a year later, and people who were diagnosed and they were alive 10 years later.
But I didn't know whether.
No, but what I will tell you is that you can follow these stages, and if they're at, let's say, they're having difficulty with getting dressed or etc., it's not going to be too long before they're also having difficulty with toileting issues and then with speech and understanding. So it gives you a sense that, now how long it's going to take to get there, I can't tell you, but I can tell you that it will get there. Okay. Yes. Yeah, Jerry has this. Yeah, no, you don't take notes, because then you're going to ask me something and I'm going to forget what I wrote down. I think So actually, to answer your question, okay. So this is a study that was done in a nursing home. It's about 323 nursing home patients who all had a diagnosis of severe dementia. Okay, so they'd already been all the way down. We're in the 7s now, okay? They're unable to toilet. They're unable to, probably couldn't speak. They had severe dementia, okay? And they had a cognitive performance scale, which is done on admission to a nursing home, of 5 or 6. It only goes up to 6, and 6 is profound dementia. And the global scale that we talked about, it was stage 7. So you remember that person was in bed. And they looked at how did these people do over the next 18 months, a year and a half. And again, this is the starting point is severe dementia, okay? So in a year and a half, 55%, just over half, had died, which means that just under half were still alive, okay? The 6-month mortality was only 25%, okay? 75% of those people with severe dementia were alive a year and a half later, okay? The median survival for that cohort was 1.3 years, okay? And this is similar to people who have end-stage breast cancer or end-stage heart failure from the time of diagnosis to death. So this is a very severe disease, obviously, but they can live with that disease for a long time, okay? Next. They looked at what sort of symptoms did these individuals have. And again, we're talking about advanced severe dementia, okay? About half had difficulty breathing. 40% had pain, and I can tell you that's way underestimated because those people would be unable to express that they had pain. And unless you were looking for it, you wouldn't necessarily know it. So ignore that, that's nonsense. 40% had pressure ulcers. 40% had overt aspiration when they tried to feed them. They aspirated it, either went to the lungs or they vomited after eating, okay? Over half had agitation, which you're going to learn about next week. And in this group, over 85% had difficulty even just eating or swallowing, okay? 85% in this group. Next. 6-month mortality, they looked at what happened in the last 6 months with these people with severe dementia. About half had a pneumonia that may or may not have taken them. About half had a significant infection. That's what the febrile illness was. And in the last 6 months in this group, 40% had eating problems. Next slide. But by the last 3 months of life, over 90% had developed eating problems. So this is going to be an issue before the end of life, unless they die of some other cause. Certainly people with dementia can have heart disease or cancer or anything else, okay? But in the last 3 months of life, and again, this goes with planning ahead, about 40% had severe pneumonia. Again, a third had a serious infection and eating problems in greater than 90%. I would say it's 100%. I mean, none of those people were eating like the nice meal that we had at lunch today at Brindy's. Okay. So, what? Yes, did you have a question?
Yeah, I just wanted to briefly address the eating. My husband is in memory care and he is in late stage. He has not lost his appetite, but I think that I end up feeding him because he can't figure out how to feed himself, but he hasn't lost his appetite. So I don't know if that falls into eating problems.
No, he's still eating,
yeah,
right.
But he'll sit there and he'll take his fork and he'll run it over here, way away from his plate, and then bring it to his mouth.
Yeah, that doesn't count as an eating problem because he's eating if the food gets to his mouth.
But see, I kind of wonder about where he's at. I really do wonder.
Yeah.
Because sometimes I'm like, if I'm not there making sure he's eating, would he be eating or not?
Well, hold on to that thought because we're going to get back to it, okay? So when we have any terminal illness, doesn't matter what organ is failing, and we're making decisions for an advance directive or power of attorney and that sort of thing, we have to think in terms of quality of life versus artificially extending life, right? And that's going to be different for every person. There's some people that say, I don't care what it takes, don't let me die. Well, eventually that's going to happen, but there's situations that, yes, I mean, you get yourself into a situation that probably got out of hand because they didn't really understand what they were talking about. But anyway, any decision is made in the context of quality of life versus quantity of life. And that can be very difficult to think about when we are not end stage. And so one way to think about it when you're making these decisions is to think, what is a quality of life that I would not accept, okay? Instead of saying, well, would you want this? Would you want this? Yeah, I'd like that. Well, what is a quality of life that you would not accept if the only way to get you this and that was like on a ventilator or something like that? So what is a quality of life that I would not accept? If you would not accept not being able to recognize anybody, not being able to control your bowels or bladder, being bedbound, and all of the other things that we've talked about, if that is a quality of life that you would not accept, then it's your perfect right to say, I don't want to be kept artificially in that condition. Okay? So that's an easier way to deal with decision making. What is a quality of life that I would not accept? Okay? And remember, as I said, that loss of appetite and interest in eating is expected at the end of the diseases of dementia. It's expected. Okay? So it is something that needs to be discussed. Because I can tell you that if somebody, like if your husband, if he were to stop eating altogether and there wasn't something in place and you weren't there to speak for him, and somebody else was making a decision for him and it hadn't been written down, he's going to get a feeding tube. Okay? Because doctors are not going to make value judgments for people. They're just not. Next. So if we look at the issue of feeding tubes in particular, and again, this is in the context of dementia, there's many reasons to give somebody a feeding tube that makes perfect sense. If they've had esophageal cancer and they're otherwise up and about, yes, putting in a feeding tube makes perfect sense. If you're getting them through a period where they are expected to then be able to live a normal life afterwards, sure, there's many reasons to put in a feeding tube. But in dementia, we're talking about at the point that they stop eating, they're not turning around, okay? But when you look at nursing homes in general, up to a third of those patients are being artificially fed. That's all comers in a nursing home. Okay, a lot of those are dementia patients. The reasons given to put in a feeding tube, and be prepared for this because if a discussion comes up with a gastroenterologist or somebody else, this is what they're going to tell you. Well, it prevents aspiration. It prevents malnutrition. It'll improve their nutrition. It'll improve the healing of pressure ulcers, and it'll improve their functional status and patient comfort, okay? Those are reasons that are given to put in a feeding tube. Next slide. When you actually study this, there is, and particularly feeding tubes in dementia, there is little or no evidence that they improve clinical outcomes. And there is a lot of evidence that significant harm can result from placing that feeding tube, and we're going to go over that right now. Next. Okay, this was one of the more recent studies in 2020, but this is exactly the same as the studies that I looked at back in 1999. Okay, this was a review of 1,800 patients with advanced dementia who received feeding tubes. They had a higher mortality rate with no improvement in the survival period. They had an increased rate of pneumonia. They had an increased rate of pressure ulcers, and they did not improve nutritional status based on laboratory studies. And they also did not improve their quality of life or their comfort because for many patients with dementia, when they have a feeding tube in, they wind up in bed and they're restrained because they're trying to yank that feeding tube out. They're confused, they don't know what's going on, it's uncomfortable, and now you have somebody who is in bed. They may be tied down, which will guarantee that they're going to get a pressure ulcer. It will guarantee it, okay? Also, if you're lying in bed, you are going to aspirate because whatever goes into the stomach is going to track right up the esophagus, okay? When everybody in this room eats, when we swallow, the reason the food doesn't come right back up, unless we're sick, is that there's muscles that contract, keeping food going in the right direction, but there's a large muscle at the bottom of the esophagus, right where it enters the stomach, called the esophagogastric junction. And that muscle closes when we swallow to keep the food from coming back up. If you bypass that by putting a feeding tube directly into the stomach or through the nose down into the stomach, that muscle doesn't contract. And so liquid, in the case of feeding tubes, is going to track right back up the esophagus, and it can go into the lungs. Or if you have a feeding tube that goes through the nose, it'll just track right up along that feeding tube. So it's important to understand what we're talking about because the people who put in these feeding tubes will act, well, it's just no big deal. Well, it's not a big deal for them, okay? And I can tell you, I have had many, many discussions with families that had met with a gastroenterologist and they really didn't understand what was going on, okay? In fact, not that long ago, somebody from Green Valley got my name and called up, and they were being sort of pressured into getting a feeding tube. We went over the whole thing, and they really hadn't understood what was going on. Okay?
Before that happens, are they given a decision? I mean, does the family make the decision? Are they asked?
Well, yeah, somebody has to consent for that procedure because it's a procedure. But the thing is, if the discussion hasn't occurred, and let's say that they ask you, but you're not the durable medical power of attorney, or you're not the spouse, even a spouse can be kind of iffy, because if you say we're a second spouse and the first spouse is coming in saying, wait a second, I'm going to sue you, that's why you have to have things in place. Or the daughter from California shows up and says that, no, you're trying to kill dad, right? And that's why these things have to be in place, particularly with dementia, because it'll only get worse. Okay? As far as improving comfort, we just went over that. It's not possible that it improves comfort. They can't enjoy the food, they're restrained, and they can have pain and discomfort from the tube itself. Next. Aspiration will occur in about 2/3 of them. Occlusion will occur in 35%, leaking in at least 20% in my experience. Local skin infection, it's higher than that. And about 60% of these tubes are going to require replacement for all of these reasons. And generally, it's not going to be at the bedside. So now you're taking somebody who's confused, putting them in an ambulance or a car, an ambulette, taking them somewhere. They have a procedure that they don't understand, and then you go round again. Okay? But it's important to understand all of these things, because that's what goes into decision making. Okay? And it's not, well, you're killing them, you're not feeding them. That's not the issue. Part of the disease is that they will stop eating. That's understood. Okay. Don't stop too early. He's still enjoying food. Okay.
You just can't find it.
Well, exactly, and that's why you're there. Next. All right, so getting to your issue, now we're going to talk about, so what are the alternatives to feeding tubes? Well, the best alternative is hand feeding the individual. And we say hand feeding the individual, it's exactly what you just described, okay? Because they can't find the food, they can't use a fork, okay? We've already determined that they can't use utensils and etc. But they can be fed, and if they're hungry and they want to eat, then you put the food in their mouth, small amounts, and they will eat it. You sit them upright, you make sure that you're giving them something that they like. This is not a time to say, well, this food is good for you or this is bad for you. Forget that. If they like ice cream is the perfect food, okay? Whatever they will eat is what they should eat, yes?
No, I was like, yes to ice cream.
That's right. Ice cream is the perfect food. You think about it. And if that's what they want to eat, that's what they should get. Small amounts, sit upright. Now, if it gets to the point that they're starting to tongue out that food or they're clenching their teeth, they don't want it, okay? The thing is that nutrition, why do we eat anyway? To give us energy, but I mean, ultimately, why do we eat? How do we keep alive? It's all about the cells, right? The reason that we eat is to keep cells functioning in our body. Those cells require all the micronutrients to do all of the thousands of reactions at the cellular level. It requires liquid because 70% of a cell is liquid. Almost all of these reactions at the cellular level are in an aqueous solution. And so the reason that we eat is to get all of these fats, amino acids, sugars, and then all the micronutrients to get down to the cellular level. That's why we eat, okay? And when the body is going through a process that it's preparing to die, the cells don't want that. The body doesn't want it. The brain doesn't want it. And when we try to artificially feed people, bad things happen. When we give them too much fluid IV, bad things happen. And I've seen it happen time and time again. The body just can't deal with it, okay? So when we're hand feeding somebody, you can actually make an assessment. Now, yes, it takes time, and that's why it's not done a lot, to be honest with you. But if there's family that can do it, or if you can hire help to do it, or make sure, like if they're in a care unit, to go in at meals, somebody goes in and helps to feed them, and etc. It's also a time to socialize, which is terribly important. I mentioned that all of our emotions are in the brain, but they're in the deepest part of the brain. They're in the last part of the brain that's going to die, okay? We don't die from the heart. We die from the brain stem, okay? And our emotions are just at the brain stem and above, okay? That's where our emotions are, the deepest parts of our brain. And so those are going to be the last things that leave us. Now, the person may not be able to express it because that's further up on the brain. That's in the temporal lobes of the brain, our ability to speak or to understand the spoken or written word. But as far as emotions, no question that people have a sense for, love, pain, all of these kinds of things. Just because they can't express it doesn't mean that they're not experiencing it. So hand feeding, or even just sitting and talking to somebody with very end stage dementia is the right thing to do. Right? Next.
Question.
Yes.
Regarding liberalize the disease that they
Yeah.
enjoy, I understand this is for stage 7. How soon?
Stage 6, stage 5.
Okay, thank you.
If the point is quality of life and they want something, let them have it. Okay? It's not the time to say, no, I know you hate kale, but I'm going to make you a kale smoothie because it's good for you. Okay? Because they're not going to enjoy it if they don't enjoy it. Now, maybe some people like kale, I guess. But liberalize the diet and do it early. Okay? I mean, if somebody's been given a diagnosis of dementia, they've had it for a while because it's underdiagnosed. If you look at the time in retrospect, from the time that they could have been diagnosed, in retrospect, to the time that they were diagnosed, it's generally some years. Okay? So they have had dementia by the time that's diagnosed. They've had on the continuum of dementia, they've had it for a while. And so it's going to continue. And so that actually is the time to start having these discussions and be changing how we approach that individual based on quality of life. Okay? How long that individual is going to live, who knows? But I'll tell you, if you're feeding them something that they enjoy, they're probably going to live longer. Okay? Because they're getting enjoyment out of life. Okay?
Is there any advantage to having the early diagnosis as opposed to letting it progress and then diagnosing them?
Well, what I would say is that based on everything we're talking about today, the earlier the better, because somebody who has advanced dementia, somebody else is making their decisions.
Right. But I mean, if you have everything in place,
Mm-hmm.
and
But that can change. It all depends on what people's understanding were when they put everything in place. And we're going to talk about that a little bit. Okay. So I would say, just like with heart disease or any other disease, no, there's no advantage to waiting until it's advanced. I can't think of any. I'm not sure.
I'm just thinking, well, let's just take myself, for example. I mean, I don't think I have dementia yet, but if I knew I had dementia now, I have all my paperwork, everything's in place as far as my paperwork goes. But if I was diagnosed with dementia right now, I think that would affect my quality of life.
Well, I mean, who's going to keep that diagnosis from you? I mean, how you went to somebody to be diagnosed? Did you go to a doctor, or I'm hypothetically?
Yeah, right.
Who's not going to tell you? Now, if part of what you wrote is I don't want to know a damn thing, then fine. But I can't think of a reason to keep information from an individual, especially when we're talking about something where they will lose capacity to make a decision for themselves. And just because an individual has written something down, you're probably going to learn something today that you didn't know unless you were an ICU nurse or something like that. Now, I don't know your background, and we're not, I don't want to put you on the spot. But people fill out this stuff without really knowing exactly what it means. Okay, and that's why we're having this discussion today.
But isn't that hard for doctors to say that?
Apparently, because they don't.
Yeah, I know.
I mean, my job as a palliative physician was I got referrals by doctors who didn't want to have this discussion. And then the patients got PO'd because I came and had the discussion. And they weren't getting it from that doctor. So yeah, I mean, but somebody's got to bring some reality to the situation. You know,
When we were standing here talking before the meeting started, and you basically diagnosed me, saying that I do not have dementia.
right.
Well, I know it when I have it.
What I will tell you is that early on, yes, the person is going to be aware that things just aren't the way they should be. The diagnosis of dementia, this is the diagnosis of dementia. If on the basis of cognitive decline, an individual is unable to care for themselves with their activities of daily living, their instrumental activities of daily living, you know, like taking care of their finances and etc., on the basis of cognitive decline, that is dementia. Anything less than that is not dementia. It may be mild cognitive impairment, it may be some other term that somebody's going to use, but dementia means that the person has lost the ability to care for themselves. That's dementia.
Just because I'm 90 doesn't mean anything.
It means you've lived 90 years. That's what it means. Yeah.
Yes, then.
Did somebody else raise their hand? Okay. So again, getting back to this question of diagnosing early, okay? With an early diagnosis, then the individual and the family can start looking at, well, what medications is this individual on that either are a problem or can become a problem, and start to wean things down. Because it has to change the way you look at that individual. They now have a diagnosis, and we know that it is going to follow a pattern. How quickly it follows that pattern is unknown, but it will follow that pattern. All of the stuff that you hear about, well, it improves their cognition and all this other stuff. There is no drugs that really change that pattern. They might change the slope from this to this, but that slope is still that. But at what cost? And I'm not talking about financial cost, okay? So there are some medications that early on can sort of slow things down, things like donepezil, you know, Aricept and some of those medications. Sure, I would give them a try. Whether or not they do anything, you know, it varies from individual to individual, but they all come with side effects. So if somebody is continuing to decline in spite of these medications, it's probably a good time to stop it, because they will develop problems with swallowing at some point, and you don't want it to be choking on a pill that they didn't really need. So the medications that really need to be reviewed and thought about are these. Anti-lipid agents. Okay, we're no longer concerned about their cholesterol. In fact, if their appetite is decreasing, they don't have a cholesterol problem. But anyway, the only reason that we treat high cholesterol is to decrease the risk of heart disease 10 years from now. Okay, that's why it's treated. Same thing with hypertension, blood pressure. Same thing. Anticholinergic medications like cold medicines and those sort of things are very drying, and many other medications, including some that may be discussed next week. You know, some of the medications, the antipsychotics and stuff, they can be very drying too. So you have to weigh how much is this going to be medication versus non-medication involvement. Medications that are used to make our bones strong. Again, they come with a lot of side effects, potential side effects. It might be a good one to stop. Blood thinners. Yes, if somebody has a heart valve and they need it, don't stop it. But if they're just on it because they had a heart attack 10 years ago and it was just sort of kept on because, it may be one to stop. Because if this individual falls, and remember, part of that decline is going to be inability really to walk without assistance. If they fall and whack their head, they can bleed into their head. They can also bleed into the GI tract, and etc. These medications come with side effects, right? So you think about these things and you ask the doctor, why is he on it still? And not in an accusatory way, find out. Does he need this? Is it something that we can stop? And you can always stop a medication by taking half the dose and seeing what happens, okay? In fact, with blood pressure medicine, you generally don't want to stop it abruptly, but cut the dose in half. See what happens. If everything's just fine, cut it in half again or stop it, okay? Same thing with diabetes medication. In all likelihood, they're going to be better controlled as far as, like say, their hemoglobin A1C when they're losing weight, okay? They don't need that medication. And again, you know, you can always check a blood sugar if you're concerned about that. It's easy to do. Hormone replacements, again, for the men, testosterone replacements, probably not going to be an issue for very long. And for women, estrogen replacements, again, why are we taking it? And is it something that we can stop? Is it necessary? And then chemotherapy. If somebody who has dementia also is diagnosed with a cancer, well, you weigh, well, why are we treating the cancer? If they're already dying, they have advancing dementia. Again, that's a value judgment that I can't make and no doctor should make. The doctor should talk to you about the pros and cons, but the individual or the family should make this decision. Again, getting back to like an early diagnosis, okay? If I was diagnosed with dementia, and I may be, my father died of dementia, his father died of dementia, and so I hope I'm making sense. But if I was diagnosed with dementia, yeah, I would want to know if then I also had a cancer, and I would want it treated. You know, just feed me ice cream, right? Chocolate, yeah, but some kind of cake, yes.
So is it appropriate to ask our physician, what would you do in your advance directive?
It is, and you may be surprised what they say. Absolutely.
Or what would you advise for your mother?
Well, that's a good question. In fact, I've used that many times. In fact, I've used the other, if your mother could talk to us right now, what would she say? When you have the family there and mom is on a vent. And most of the time, she'd tell us all to go to hell. Next. Okay, so what about pain? I mentioned that earlier on. Okay, we know that with aging, the perception of pain does not really change. Okay, the superficial, you know, pain from the outside or joint pain, etc., doesn't really change with aging. Now, we do also know that chronic illness and things like arthritis, etc., increase the risk of pain. And so if somebody is laying in bed not moving and you move them quickly, they're going to have pain, right? So, but they may not be able to express it. So pain is way under appreciated in aging people in general, but people with dementia in particular. And one rule of thumb is, look, if it would hurt you, it hurts them. If they can't speak for themselves, if whatever you're planning to do would hurt you, it hurts them. Next. Okay, so how do we evaluate pain with somebody who can't verbalize? Well, I mean, it's the same thing as a mother looking at their baby, okay? It's the same kind of thing. You look for nonverbal cues, frowning, grimacing, a fearful expression, crying or whimpering. Now, agitation and combativeness, this is something that you do need to pay attention to because pain often results in increased agitation and combativeness, okay? There was a patient during my fellowship, one of the other fellows was taking care of this patient in a nursing home, and he started punching out the nurses when they went to change his diaper. And so they put him on medication and everything, and he was becoming more agitated, et cetera. Well, ultimately, they sent him for an x-ray, and he had a fractured hip. Yeah, well, they tied him down is what happened, okay? But anyway, he couldn't say, but that was what was going on. Change in behavior, basically the same thing with this, and sleeping poorly. So, and then just, you know, is the position that they're in, the condition they're in, would it cause pain? Yes. So move them gently. If you're going to sit them up, do it gently. We all know how we feel if we've been sitting in a car for an hour and a half on I-10 going someplace, and you get out to stretch your legs, and at first you can't stretch them, right? And it takes a little while to move around. Well, they have the same thing, they just can't tell you. Next. Okay, so let's talk about, any questions so far? Yes.
What's the likelihood of someone moving to harder drugs if they have dementia?
When you say harder drugs, what do you mean?
Natalie Wood died of moving to harder drugs.
I mean, there's always harder drugs. I'm not, I'm not sure I understand the question. You mean, are they being put on opioids, for example?
Yes.
Uh,
She switched to overdose,
mhm.
ran out, went down to their yacht on Catalina Island, fell into the bay and drowned.
That's the story.
I got the story directly from Bob Wagner's best friend, who was also his.
Well, I can't speak for Natalie. Okay. I think the question is, do these patients get put on stronger drugs? And yes, I'm sure opioids are, well, I know the opioids are used because we use them a lot in hospice and palliative care, but you use them carefully. And you make sure that, for example, if they're going to be on something like morphine, either under the tongue or something like fentanyl, a lollipop, fentanyl comes in a lollipop form, you just put it in their mouth and it slowly gets absorbed into the cheek, and it works extremely well. But you make sure that you're also treating their bowels, otherwise they're going to get constipated and that sort of thing. So yes, opioids are used. I can't comment on poor Natalie. But a lot of people take drugs, and that's why it's a huge problem, and with a lot of people dying every year. All right, so let's talk about advance directives, durable medical power of attorney, durable power of attorney, and guardianship, okay? This is important to keep in mind and kind of gets back to your question, okay? At some point, the individual with dementia will lose the capacity to give legally binding consent for treatment, to make a will, to state who's the power of attorney or the durable medical power of attorney. They are going to lose legal capacity, because the definition of legal capacity is the mental ability to understand the nature, consequences, and risks of one's actions, decisions, or agreements, okay? Now, at what point do they lose that? That's for a court of law to decide, but I can tell you that if you wait too long and somebody challenges that power of attorney or that will or whatever, and they were diagnosed with dementia and they have advanced dementia, if they signed it, it could be challenged, and it'll probably, some judge is going to make a decision, okay? So like I said, I can't really think of a reason to ignore a diagnosis like that, particularly for this reason, that these have to be put in place. Now, in general, a spouse is recognized as the de facto power of attorney, but not always. If it's a second spouse or if there's a family member, if you have a family fight going on, it's only going to get worse. Okay, I can guarantee you that these situations will make it worse. So you need to have these things in place. And a durable medical power of attorney, durable means that it continues after the person has reached this incapacity. Same thing with a power of attorney for financial affairs. If it's not durable, then it ends at the point that the person loses capacity.
What's the difference between guardianship and conservatorship?
Well, a guardian is stated by the court. Conservatorship, I don't know, it's probably about the same thing. Now, these may come, it really depends on the situation of the individual. If it's a clear family relationship, a marriage relationship, and et cetera, and there's no outside issues going on, then, a durable medical power of attorney and a living will, et cetera, will probably be fine. But the more there is issues going on, the more you want to make sure that you went to an attorney and you did it correctly, okay? Because even with that, if it's challenged, it's going to go in front of a judge. And the judge is going to ask, well, what was the capacity of the individual at the time they signed this paper? Especially if there's any finances involved, okay? So earlier the better. All right, next.
Sir,
Yes.
does the guardianship take precedent over POA?
Yes, a guardianship is declared by the court. The guardian's the guardian.
Okay.
Yeah. Now, if there's
Durable power of attorney is just a statement that is.
Well, a durable medical power of attorney is a legal document.
I've got that with my wife.
And it doesn't need to be done in front of an attorney. I would, because I just think that There's so many issues that can come up. You're better off making sure it was done correctly.
The guardianship does not necessarily mean that that person is at home.
No. In fact, many people in nursing homes, they have a guardian. If somebody's in a nursing home and there's no family, they're going to be assigned a guardian. Okay, so when we're talking about advanced directives, what does a DNR mean? Okay, so you all know what the 3 letters are. What does it mean?
Do not resuscitate.
Right, I get that, but what does it mean?
If they stop breathing, let them stop breathing.
It means only that in the event of a cardiopulmonary arrest, no CPR will be started. That's all it means. It has no impact on any of the other issues that we've talked about. So when people say, I'm DNR, fine. It just means that if you suffer a cardiopulmonary arrest, CPR will not be initiated. Unfortunately, it still is all too often, but that's besides the point, okay? So when we're talking about an advance directive, just to say, well, I want DNR or however you want to phrase it, that's fine for that particular issue. But all of the other issues need to be discussed specifically, okay, for an advance directive. And so you need to think in terms, okay, for CPR or DNR, it applies only to cardiopulmonary arrest. And I can tell you in this situation, if the person does suffer a cardiopulmonary arrest, CPR is not going to improve their quality of life or their baseline. The best that you could hope for, if the point is to revive them, is that they return to the condition that they were at the time that they arrested. Okay? There's nothing magical about CPR, except that now they probably will have fractured ribs and they have suffered a cardiac arrest. And so
How do you
if,
feel about this?
I'm not sure what that is. It's so like, help me, I can't get up or whatever.
No, it's just my, it will go off if I push the button,
Okay.
and then they'll come after
Well, don't do it right now. Actually, you could, and we'll see what happens. No, you better not. See if it's worth anything. And first of all, in this age group and in this condition, the chance of, quote, success is remotely small. Yes, you might be able to get a heartbeat and even a pulse, but that individual certainly is not going to be discharged to home to take care of themselves. Okay? The best you can hope for is that they return to the condition that they were in before the cardiac arrest. The chance of that happening is extremely low.
Second string.
Yeah, the second string's in, see if I can deliver.
All right, take care. The next thing is to think about hospitalization. Okay, we're not talking about necessarily early on at all. But if an individual is in a condition with a quality of life that they would not accept, it's perfectly okay to have in your advance directive, do not hospitalize. And that can be for a nursing home or for in your own home. And the question is, if they have, let's say, a pneumonia, if it can be treated in the nursing home or at home and you want it treated, we'll try that. But if they're not doing well, if they don't get better with that, we do not want them hospitalized, and we want comfort measures. Okay? And we're going to talk about how you can move to comfort measures. Okay? There's a thing online that you can look up if you want. It's called the Dartmouth Dementia Directive. And this is from Dartmouth University up in New Hampshire. And it's a very detailed form. And I only reference it because it may help if people have questions about it. But they go through all of these issues that come up with dementia in particular. Okay? Because we're talking about the diseases of dementia. And so this is helpful. Just put in Dartmouth Dementia Directive and it'll take you to this. And there's a lot of information and it can be very helpful. It may raise things that you hadn't thought of before. Okay? But it's perfectly fine for an individual. We have the right to refuse treatment. Okay? We also have the right to stop treatment if it's been started. Okay? Now, you might get some pushback, but that is your right. Now, if you don't have legal capacity, you want to make damn sure that whoever's speaking for you has the same idea. And so you have that discussion ahead of time, right? That's what the durable medical power of attorney is, right? Next. Okay, so we're going to talk a little about the hospice, the Medicare hospice benefit, okay? In the United States, most palliative care, now it's slowly changing, but way too slowly. Most palliative care, and palliative care is care that's directed towards quality of life, not quantity of life, okay? It's not just comfort care. It's like, well, what's important to you? And let's see if we can get you there, okay? It's not, you have this, you need this. It's starting with the individual. But most palliative care is provided in the hospice benefit from Medicare, which was started back in 1983. It's over 40 years old, and just a year ago is the first time that 50% of people on Medicare who passed had used the hospice benefit, which is their right. They've earned the right. But in any event, it's way underutilized. And we're just going to be talking about the Medicare hospice benefit in the context of dementia, okay? Every single disease has its admission criteria, whether it's Parkinson's, whether it's heart disease, whether it's liver failure, whether it's kidney failure. There's special criteria that the individual must meet as far as decline, level of decline, before they're admitted to hospice. Because the hospice benefit was set up to provide care in what's expected to be the last 6 months of life. Now, nobody knows exactly what that 6 months is going to be. But based on studies, we looked at, again, we just saw a study where they saw, well, how did these people do over 18 months? If you look at the last 3 months or 6 months, many people had these conditions. And so is that individual in that group? And that's up to the physician in the hospice or the patient's personal physician to decide if they meet this criteria. But one of the criteria for dementia is that they are at least down to that 7C. And remember that if they're 7C, they've already lost all of the things above it, okay? They're speaking one or less intelligible words a day. They're basically full assist with everything. They can't walk. They can't sit alone. They're incontinent of bowel and bladder, and et cetera. All of the things. Their intake is decreased. And they also should have had a weight loss greater than 10% in the last 6 months, which indicates that they're starting the process of not eating. And you can also check a low albumin. If you do, the albumin should be less than 2.5. But then we also look at other things. Do they have heart disease? Have they had a stroke? Any of these will add to the criteria to get that individual admitted to a Medicare hospice program. Okay, but if they're still up walking around, they're not going to be admitted, even if they have lost 10 pounds and et cetera, because that person is still out and about. Okay. But if that individual is basically total care, it's time to call a hospice program and have them evaluated. They may not meet criteria, but at least you've got them plugged in. You also will have a discussion so you understand what this benefit is, because it comes with a lot of services that are required under the Medicare hospice benefit. Next. Okay, and these are some of the benefits that are required of every hospice program. You will have the patient's regular doctor can be as involved as they want. Most people, I would say, in reality, choose the hospice physician because their care sort of has transitioned to a different state, but certainly their own physician is involved and can be one of the physicians that...
I have to tell you that when my husband was admitted to hospice, we got a call from the doctor that ordered it, and he said, I can no longer be involved.
That's not true. All I can tell you is that's not true. That may be what he said.
But I've heard that from you know, I've been involved, they all seem to say that down here.
You know, people say a lot of
They
things.
say use the hospice physician.
People say a lot of things. I'm just telling you that that's not true, but most physicians will
Wow.
transition. Because, well, first of all, that physician probably isn't trained in palliative care, where the hospice physician is. But I will show you, I'm gonna go over this, so you learned something today.
Yeah.
All right? There's also nurses like Lynn, LPNs, social workers involved to help navigate a lot of things. There's a bereavement team because this benefit lasts for a year after the death with the family. Okay? So they will help you through the process of dying and then remain in contact for a year. Okay? If you don't want them involved, you just tell them, I don't want you involved, but it's a good service. There's volunteers that can help with hand feeding and et cetera. There's spiritual care. Every hospice has to have a spiritual advisor. And then there's the nutritionists that are required. It's occupational therapy, physical therapy, and nutrition. So they do an assessment, okay? So these are, and it's geared around the family with the patient as the center, family or caregivers, okay? So these are the services. Now, some hospices have other services. They have music therapy. They have all kinds of things. You know, if you're in different parts of the country, you know, they're all competitive. And unfortunately, greater than 90% of hospice is provided by for-profit companies. They've figured out how to make money at this. Yes, Lynn.
I have a question. If the doctor wants to no longer care
Next.
for the patient, obviously I don't want them, but could we, is that law? I mean, or can we
Yeah,
say?
can I get to a couple of slides here?
Can we threaten
Can
them
I-
with abandonment?
No, because you're not no, because the hospice physician is taking over. You're not abandoning that patient. Why would somebody feel so strongly about having a physician involved that didn't want to be involved?
Exactly, but if someone said, I want that doctor, because
They
you've
can-
known
they
him
can
for
keep 'em.
50 years.
They can keep him, but the hospice physician is going to be involved too.
I think
You're going to get a hospice physician.
Yeah.
It's required. It's under the Medicare hospice benefit. The hospice physician will be involved because they are going to certify that this person meets the criteria, and they're going to recertify them every 90 days or then every 60 days after two 90-day
I
periods.
understand that, but if the family member says
Fine.
to the doctor,
Yeah.
I want you involved, otherwise I'm going to say it's abandonment.
Well,
then-
see, I mean, why do you want that kind of relationship with somebody?
I'm wondering if.
Well, why would you want to have that kind of relationship?
I personally-
Okay, good. So let's not do this. I am just telling you what the law is, and if you let me go through another slide, I will show you the law. Okay? Thank you. Lynn and I go back a long way, so. All right. So Medicare Part A provides the primary hospice coverage. So Medicare A. And it will cover all of the medical services that the hospice team provides. Not that other doctor necessarily, but we'll get to that. All medications for pain and symptom management, durable medical equipment, a hospital bed, et cetera, commode, not the walker for dementia, but other diseases. Certainly they can have a walker. Some personal care, help with ADLs and comfort needs, feeding, et cetera. It will provide short-term inpatient respite to relieve the caregivers because most of the hospice services are in the home, okay? And so for a short period, they will cover inpatient respite care. And then if necessary, if you can't control the symptoms at home, it'll cover inpatient hospice care at an inpatient hospice unit, right? Next. Beneficiaries, Lynn, maintain both parts A and B. Part B may cover healthcare needs unrelated to the terminal illness, for example, care provided by the regular doctor. We always start from the premise of the regular doctor being one of the doctors who will certify 6 months. Most of them say, I don't know, and then it's the hospice physician that certifies it. It has to be certified by a hospice physician. And every certified hospice has to have a hospice physician. It can't be certified by a nurse practitioner. It has to be by a physician, an MD or a DO. Okay? You can look up this law if you want. And then any care that is provided outside of hospice, of course, is provided in coordination with the hospice team in the context of the goals of care. Again, are we going to be doing colonoscopies on people who have end-stage dementia? I would hope not, right? But a doctor might say, well, he had blood in his stool. Well, we need to get a colonoscopy. Okay? Now, would Medicare cover a colonoscopy on a severely demented individual, somebody who's on hospice with dementia? No, they would probably require that individual disenroll, and they could then get the colonoscopy, which they would pay for, but they wouldn't be being covered by the hospice benefit because the goals of care had changed, right? The only reason that you would do a colonoscopy is to see, is there something in there that we can do something about? Is there a malignancy? And if you find a malignancy, are we going to do surgery or whatever? So it's not comfort care, and it's also not going to change the outcome because we've already determined that the individual has very end-stage dementia, right? So it comes down to goals of care. But yes, the primary physician actually should remain involved, ideally, but most of them don't. They're not trained for it, okay? So there's that. Next. Any individual can self-refer to hospice, or any family member or a friend could refer an individual to a hospice program. You do not need a physician referral. The hospice program will then do an evaluation, and they may or may not admit the individual to the hospice program. But anybody can refer an individual to hospice, okay? And self-referrals happen often. A person's regular doctor or another doctor may certify hospice eligibility of 6-month expectancy along with the hospice physician, who must sign the paper, okay? The hospice medical director has to certify, as I just said. There are 2 90-day enrollment periods, and at the end of the enrollment period, the patient is recertified by the medical director, and then an unlimited 60-day recertification period, and it's a 6-month benefit, but if you live more than 6 months, you're not going to get kicked off just because you've lived more than 6 months. If you no longer meet criteria, you may be discharged, okay? And this becomes an area here that it really depends on the hospice. My feeling always was, look, if we're going to admit somebody to hospice, we're going to give them at least the first 90-day, 3-month period. Some hospices want to discharge people as soon as they start looking good. And most people are going to start looking good when they get on hospice, unless it's too late, because they're getting a lot of care that they should have gotten. And I will show you how late next. All right? If you look at the length of stay on hospice with a primary diagnosis of dementia, which is about 16% of all enrollees into hospice, Medicare hospice benefit, 30% were enrolled 1 week before they died. Way too late, okay? The median length of stay, again with this cohort here of dementia, 27 days, less than a month, okay? Remember, this is a 6-month benefit, is what it's designed. They're being referred way too late. If you look at the average length of stay, yeah, it's about 5.5 months, and people are getting worked up about that, except that's still less than 6 months as far as I can tell. And this is because there are some outliers that push those numbers way up. But these are the 2 numbers that really are quite striking, okay? 9% only are enrolled for greater than the 6 months. So even though there's a big discussion about dementia and people are on it too long, the facts don't bear that out. 9% is fine. Jimmy Carter, by the way, was on hospice for 2 years. He didn't have dementia. He had melanoma of the brain. But he was on hospice for 2 years. If he can be on for 2 years, somebody else can too. Well, as far as I'm concerned. Next. Now, frequently before an individual passes, they have a little rally, and I've seen that also with dementia patients. They start to look good, but certainly with many other diagnoses, and we call it the golden glow. So this is the golden glow for all of us, that remember at the end of the day, we usually get a golden glow, unless it's raining. But so I would strongly encourage that if you don't have an advance directive, that you get one in place as soon as possible, regardless of dementia or whatever. The earlier the better. And these can be changed. And the more we learn, the more we can also then change it for more specifics. Understand that with dementia, stopping eating is expected towards the end. And so feeding tubes is not going to change that outcome, okay? Spend as much time as you can with your loved ones.
And my understanding is that once you stop feeding them, that's not a discomfort any longer. Your body's kind of shutting down and preparing for death.
Trying to force feeding them is what's uncomfortable.
Right.
But if they don't want to eat, they're not hungry either.
So there should be less discomfort in families doing that.
Well, I mean, it really, listen, it's the opposite of what we all grew up with. You know, we feed, you know, we want to, you know, we've got to feed them, you know. But in this disease, part of satiety and hunger and everything is controlled by the brain, and it's not functioning. So they're not hungry. We all get hungry if we miss a meal. But at that stage, they're not hungry. In fact, you will see them clenching their teeth or spitting the food out. They don't want to be fed. And they're not going to die necessarily quickly when they stop feeding. You're not killing them by not feeding. The disease is taking its course. And people really have to get away from that, because especially in family strife, that's the first thing that comes up. Well, you're killing Dad. It's just not true. Okay? That's it.
Thank you. Thank you. I don't know about you, but I just appreciated the no nonsense, really just naming some hard things that are hard for us to talk about and to hear. And so thanks for being here and doing that with us today. I think Dr. Dummer will be available for some questions. Pastor Ken Benson here in the back, myself, Pastor Doug, and Pastor here both. Pastor Ken has many more years experience just in general than I do, but as a hospice chaplain as well. I also had the privilege of serving as a hospice chaplain some years ago in the White Mountains when I was serving a local church up there. In fact, I had a patient that renewed 18 months, and I watched him. I mean, he declined very slowly, but there he was, and even outlived my time. I moved off the White Mountains, and Bill stayed around.
There you go.
But there's a mystery element to it for sure. But so anyway, my thanks to you for being here today, and again, we're available for questions and further conversations if you need to. And so, bless you and have a great day. And then, what's that?
When is this available online?
Oh, Chad, when will this be available online?
Give me a few hours.
So a few hours. Yeah, so
Like
all of
2 or
the
3 hours,
presentations we have, like this one, are available at the church's YouTube channel. So you can find us on YouTube at UMCGV. If you go look for UMCGV, and you'll find all of our forum conversations that are there that we've been doing now for the past 3 years. So thanks to Chad and our tech team that have made those available. And, you know, they aren't just for you. Maybe you know someone you couldn't hear today that you thought, I wish my friend Jenny was here. I wish Bill was here. And you can forward that onto them. It's share a link and, expand the blessing. So. Oh, well, we're doing. I'm proud of this church. I'm proud of you, Pastor. Do you have a comment or another word?
Yeah, what's going to be the next meeting? Is it one next week or is it?
Oh, next month.
So next month. So it'll be just 1 month. So yep. And so okay. All right. Well, be well. Have a wonderful day.